Yeah. Hi, everyone. Welcome to the seventh episode of the PathCheck Global Health Innovators Talk Series. With PathCheck, we look towards digital solutions for the pandemic response. And I would like to point you to our website, pathcheck.org, to know more about the initiatives that we're running for India and US. If you're interested to join our Slack group, please move ahead to tiny.cc/PathCheck Slack. And to follow the previous talks in our series, please visit tiny.cc/PCF Research Talks. So with that, I'd like to welcome my organizers who helped to put together this talk. So Ramesh Raskar, Christian Glorioso, Tapritesh Sethi, Nina Resik, and Dr. Nacey Hudson. So thanks all of you for all the time you spent in putting this talk together. So a quick intro towards the talk series. We're setting up bi-weekly research meetings with speakers who are creating an impact in digital health with AI, software, and technology. And the primary goal for this meeting is to drive collaborations on AI for health or digital health with cross-disciplinary efforts from computer science, medicine, bioinformatics, and much more. With that, I'd like to welcome all the speakers today, Dr. Brian Wilder, Professor Anurag Mehral, and Professor Madhav Marathe. So our first speaker for today is Dr. Brian Wilder, who is from Harvard University and is in the Schmidt Science Fellow cohort of 2021. So Dr. Brian recently defended his PhD thesis from Harvard and would be moving to Carnegie Mellon as an assistant professor in fall 2022. His research focuses on optimization, social networks, and machine learning, with specific focus on algorithmics and data-driven methods for social impact and public health. So thanks a lot, Dr. Brian, for accepting the invite for the talk, and very honored to have you. With that, please, I welcome you onto the stage.
Well, thank you very much, Rohan and Ramesh, for inviting me. It's really wonderful to get to be a part of this group. So let me get slides up. Okay. Right. So this talk is going to be sort of a quick high-level overview of some of what I've been working on over the last few years, and I hope it'll spark interesting discussions afterwards. So at a high level, my research focuses on how we build AI that can support applications in public health, with a particular focus on marginalized populations. And so that's the ultimate goal. And then this tracks quite closely with the technical research program focused around making decisions about how we deploy public health interventions, right? And this means figuring out how we make decisions that are resource constrained, that are executed under uncertainty, and that ultimately affect complex social systems with lots of networked interactions. And so over the course of the last few years, I've worked on combinations of methods for gathering data about social interactions, for using machine learning to predict the potential dynamics of a system or the consequences of our interventions, using optimization to target interventions under limited resources. And then I've worked closely with experts in public health and with frontline workers to try to translate these kinds of technical ideas out into the field, into interventions that can be deployed and evaluated. And so in this talk, I'm going to give a quick sketch of a couple of overarching projects, one dealing with social network interventions for HIV prevention, and the second dealing with modeling and inference in the course of the COVID-19 pandemic. And I'll really emphasize that the intent of this is just to give sort of like an overall sense of the kinds of questions that me and my collaborators have been asking, and then hopefully we have time for lots of interesting follow-on discussion. And so starting out with the first line of work here. So the immediate motivation for this project dealt with homelessness and HIV. So this is a huge public health challenge. About 500,000 youth experience some form of homelessness each year in the United States alone. And one of the key difficulties here are really high rates of HIV prevalence, about 10 times that of the general population. And accordingly, drop-in centers and other organizations that work with homeless youth will conduct educational interventions where they try to raise awareness about HIV and about prevention strategies. But due to resource constraints, they don't deliver this intervention directly to all of the 100 or more youth who might frequent a given center. Instead, they recruit a small number of youth as peer leaders. And the idea is that those peer leaders will be able to spread the message much more widely through the social network that connects the youth. And so now hopefully this starts to seem like a more generalizable problem as well, right? There's lots of settings in public health where we're concerned about disseminating particular kinds of behaviors or information. And we think that peer influence is one of the really critical mechanisms for that to happen. And so this studies in the context of HIV, but my hope is that we can also think about these questions in the context of other challenges, like maybe right now we're thinking about vaccine adoption. And so we can frame these kinds of challenges as a computational problem. And so this is often referred to as an influence maximization problem. And the idea here is that we have a limited budget of up to k seed nodes that we're going to choose from a graph. And then we have an objective function, f, that quantifies the expected number of nodes that will be reached with whatever information as a result of those seed nodes that we chose. And so here, our objective f, it depends on the decision we make, the seed nodes who we select for the intervention. But it also depends on a set of unknown model parameters that I'll call theta that describe something about how information will propagate through the population. And so one common way of instantiating this in the literature is what's called an independent cascade model, where every edge in the graph is labeled with some propagation probability that gives the likelihood that if one node receives information, they'll pass it on to the node on the other side of the edge. And so there's plenty of previous work in the literature that applies basically optimization techniques to this model of information propagation or closely related models like it. And so there's lots of highly efficient approximation algorithms. But when you go to use these techniques in a public health context, you run into really a critical challenge, which is that all of these techniques assume that we know exactly the underlying graph and the probabilities describing how information will propagate over that graph, right? Basically that someone tells us the exact social structure of the population of interest. And in the context of many public health applications, this assumption is just not true at all, right? We have no information about how people are connected, how information might diffuse. And so the focus of this project was an effort with partners in social work where we developed an AI augmented intervention that we call Change, where the algorithmic portion of this aims at addressing that kind of key challenge related to lack of information about social and network structure. And so we ended up running a field trial of Change compared to other approaches that enrolled about 700 youth experiencing homelessness over the course of the last 2 years, and which allowed us to provide really the kind of first rigorous evaluation of algorithmic methods for network interventions in health. And so I'm not going to go into a ton of detail here, but I'll sketch out quickly how we think about these two challenges related to lack of information about network structure and the parameters governing influence on the network. So the system that we designed here called Change has 3 components. And so we start out by addressing lack of information about the network structure by subsampling the network. So we develop algorithms that just randomly query a small number of people and then a small number of their neighbors as well, asking them who they're connected to and building up a little subsampled view of who's connected to who in this population. And we show that you can leverage common features of network topology in order to learn what you need to while only sampling a small number of people. Then based on that information that we gather, we go to solve an optimization problem to decide how to actually target the intervention, right? Who to recruit as peer leaders. And this optimization problem then reasons about our sort of lack of information about how exactly information will propagate across each edge in the graph. And we solve a robust optimization problem that looks to find solutions which work well under a range of possible scenarios for how information might diffuse. So we ended up then evaluating this approach in an intervention that compared both the method that we developed, Change, alongside the kind of status quo method in public health, which is just selecting the highest degree nodes from the social network, right? The most popular people to be the peer leaders for the intervention. And then we also had a control group without any intervention. And so we conducted a trial where we deployed each of these techniques at each of 3 participating drop-in centers for homeless youth. And here's kind of a snapshot of the key result, looking at decreases in unprotected sex in each of the intervention arms of the trial, right? So the Change versus degree centrality arms of the intervention. And here we see at least a tendency towards faster and larger decreases in groups that received the change intervention. We can also conduct a statistical analysis where we test for a significant improvement versus the control group of the intervention. And here we find a significant improvement in youth who are enrolled in the change arm of the intervention, though not in the degree centrality arm. And so this gives us some real world evidence then that an AI augmented intervention can be efficacious in this domain, right? That we can successfully reason about the relevant uncertainties, gather just the information that we need to, and then produce meaningful changes in the population of interest with respect to some of these really key risk behaviors. And so I hope that this kind of snapshot of the results will tell you that AI has the potential to augment community health interventions, though there are still a number of open challenges to more precisely understand the dynamics of how information and influence interact with health behaviors. Rohan, how are we doing on time here?
Yeah, it's cool, Dr. Pan. Yeah, I mean, even if we run over by some small time, it's cool.
Okay, well, I can keep things brief then with the second project. So now I'll briefly mention as well some work on the COVID-19 pandemic. And so here, the focus of the work that we've done is more on the modeling and inference side, trying to understand unknowns and how these pandemics unfold. And so some of the early work that we did combined individual level network simulation alongside techniques from Bayesian inference to try to get at how the outbreak unfolded across a series of early hotspots, in this case, Hubei province in China, Lombardy in Italy, and New York City in the US. And really using the sort of capability of simulating populations at an individual level, being able to build in things like household structures, distributions of comorbidities, to try to tease out heterogeneities in things in transmissibility and fatality rates, in how many people were infected in the first wave. Then, so we built this individual level agent-based model that incorporates demographic information, and then we calibrated this model against the observed dynamics in the early stages of the outbreak with the Bayesian inference method that conditioned on the observed deaths that were seen in reality in a given location to then back out posterior distributions over the model parameters of interest. And we did this with a kind of naive importance sampling approach, which relies on kind of a lot of brute force simulation. And I mentioned this because then this kind of sparked an interest then methodologically in how we do scalable inference in complex models that can capture heterogeneity about epidemic dynamics and how we observe them. And we also used these models to answer policy questions related to, for example, the design of testing programs, providing some of the first evidence in support of rapid testing programs that can catch people really quickly and get them to isolate early. And then I'll sort of close the talk by mentioning sort of a first step along these lines that I mentioned, where these kinds of individual level models have a lot of ability to parse out heterogeneities in populations, but really depend on our ability to do inference, right? To recover unknown parameters in those models in response to the dynamics that we see in individual populations. And this becomes increasingly complicated when we have only partial observability of epidemics, which is, of course, always the case, right? We're seeing whatever we see through the lens of the kinds of testing programs or data collection schemes that we have to gather information. And then we're getting those observations over time, right? So we have a series of observations that quickly becomes high dimensional. And so here we introduced one set of methods based on Bayesian inference, where in this case, we're trying to do inference about the growth rate of an epidemic. And we build a model that operates at an individual level and allows us to incorporate a lot of flexibility about how exactly we're generating observations. So really trying to target this problem of partial observability by allowing us to actually specify things that we know, like maybe the biological properties of a testing question that we're using to detect infections. When people test positive over the course of infection, or or information about how the people that are testing are being sampled from the population. And really the goal here is to allow us to provide sort of fairly modular and flexible specifications of the process that's generating observables from that underlying epidemic. And then we propose a stochastic variational inference method that can efficiently use simulations from the model in this fairly modular way to then scalably generate posterior distributions over parameters of interest. And we find that this can significantly improve inferences compared to baseline methods when data is sparse. So for example, baseline methods don't do very well with subsample data that might be noisy at local levels. Our method can do much better in these situations because it actually incorporates partial observability into the generative process. So I'll stop here. I think the takeaway is that really tracking and intervening in public health challenges requires a fairly wide range of techniques to be able to make inferences from sparse and noisy data, to be able to connect those inferences to the dynamics of the social systems that underlie behaviors in public health, and then to intervene effectively in under limited resources. And there's a number of open questions along all of these dimensions. And so I look forward to talking to all of you about these.
Thanks a lot, Dr. Brian. That was a really interesting talk. I guess we will have a Q&A section after the talks have been completed. So yes, so thanks once again for coming and presenting your work. So I'll quickly share my screen. So with that, I'd like to welcome Professor Madhav Marathe from University of Virginia. Professor Madhav is an endowed distinguished professor in biocomplexity, director of network system science and advanced computing division, Biocomplexity Institute and Initiative, and also a tenured professor of computer science at the University of Virginia. His areas of expertise are network science, artificial intelligence, high performance computing, computational epidemiology, biological and socially coupled systems, and data analytics. So thanks a lot, Professor Madhav, for accepting our invite and giving a presentation over here. With that, I'd like to welcome you, Professor Madhav.
Thank you so much. Hopefully I can share my screen. You can see it, right? I'll make it full screen. Yeah?
Yeah, we can see it.
Okay, good. Thank you very much, Rohan. Ramesh, a pleasure to be here. Brian, it's a beautiful talk. You've done some amazing work. And I've met Brian almost 3 years back. It's nice to see the work he's done. And to others here too, some really remarkable folks that I got introduced in the last few minutes. So I will speak about the work our group has been doing. And want to thank our team first and foremost. This work is not my work by any means. It's really the work that the entire team has done. It's a very large team of us at the Biocomplexity Institute. We're also partners at various universities across the country and outside as well. And I will mention some of the work as we go along. For instance, we just started working with the Indian Institute of Sciences in India on some of the problems. So my goal is really to try and discuss some of the things that we've done with the specific goal of opening a conversation, not so much as results. So I'll give you almost a collection of different things we've done and hopefully sparks interest in this. So there's some references for folks who want to look at our work. We've been doing epidemic modeling for a while now. So first of all, I want to say why we do modeling, because it's important. A lot of emphasis is always given on predictions in models. I think that is one certain use of it, but I think models can be used for many, many other reasons. We think that models can be used to synthesize available data, to get a consistent representation of the underlying system. They can be used to provide a range of interpretations to incoming measurements. This is really important. So much information is coming in, and to put it all together in a consistent manner is not easy. Evaluation of actions and behaviors is another reasons one models. Of course, to monitor responses to interventions. And finally, to coordinate understanding among diverse stakeholders. In a pandemic like this, there are many, many different stakeholders, and models often used uh, are used by many different stakeholders in doing this. So I think I wanted to highlight this notion that it goes beyond prediction. So in the time I have, which is limited, I will describe a particular approach that we have taken. Sorry for the missing D here, but it's an AI-driven approach to doing epidemic science. The work we've been doing is really has its roots almost 20 years back when we wrote our first paper on this topic. And we took an approach much like Brian described, which is to build detailed agent-based models. And our hypothesis then was that these compartmental models, which are very useful, very powerful, lack the heterogeneity in this. And as a result, certain kinds of interventions cannot be adequately represented and certain kinds of analysis cannot be done appropriately. So these are complementary class of models. Different models are useful, of course, in different settings. So the way we go about doing this is we build a digital twin of a region of interest. We then build agent-based simulations like Brian talked about, and I'll say a little bit more again about both of these topics. And then we carry out different analysis on top of it, which is where much of the work happens that connects us to the decision makers in the end. So first of all, what's a digital twin? Uh, we want to build a representation of say a city. Let's take Boston in your case, in a form that essentially represents the city in a statistically similar manner by integrating lots of different data sets. And there's no end goal in this. It's you keep getting better and better as more and more data gets available. The idea is that you don't get an isomorphic representation for various reasons. One is privacy and anonymity, are important. So you don't want really a Ramesh or Rohan to be represented directly. But beyond that, I would argue that you cannot get such an isomorphic representation of a city that is evolving in time. But we want it to be statistically quite accurate. We don't want this to be a random city, right? We don't want people to be placed out completely randomly. So this picks up information from census, digital traces, data from NAVTech like places where you have locations, schools, colleges, all of the things, and then builds this detailed model. I think the best way to think about this is it's a social coordinate system. Basically, individuals are people in this case, or could be sensor systems on which you can attach other information and grow this. And this is how we really started this work back in 2002, 2003 at Los Alamos. And it was not a common occurrence then. In fact, this was the first time somebody built out things like that, but has now become reasonably common to try and do epidemic simulations, models such as these. So as I said, we take multiple data sets, we go through time use surveys, census data, land use data, and build this out. The papers and the tutorials that I had put out early on have details on it, so I won't go through them here. But what we had after maybe we first started doing this in the context of a different project on urban transport planning back in 1994. So this has got a long history to it because we were interested in understanding traffic then. And what we have done by now is we've been able to build a representation of the entire globe. Some parts are much more detailed than others, like US is much more detailed. On the other hand, some parts are still, although coarse, are better than other available representations. So for instance, we have been building one version of this twins for India. The plan is that at least the coarse versions of this will be made available to the larger research community in the next few months so that others can use it as well. It has been a challenging time to just get this validated and such. So the second step is to build disease models. It turns out to be a partly art, partly science. Brian talked about the larger aspect, but inference becomes very important. These are statistical models. And very specific things about COVID were incorporated when we did studied COVID, for instance, here. And then we run large-scale simulations on it. And we have worked very hard over these years to try and scale these simulations so that we can scale all the way to country-style simulations where we have hundreds of millions of nodes and billions of interactions. The reason being that if you want to study, say, vaccine allocation problem in the US, then we would need simulations like this. We often end up using it for smaller places. So what do we use these systems for? I'm calling them epidemiological workflows. Basically, connecting multiple small units of analysis into a question that a decision maker cares about. Questions such as risk of importation of disease to various parts of the world, forecasting the future course of the disease, counterfactual analysis, projecting healthcare demands, all of vaccine allocations and such. Just a couple of examples in this context that I will come to as I go along. So how do we work with decision makers is a question that might come up. Brian described in his talk the work he has done and has with folks. So the last 1.5 years, we've been working very closely with multiple agencies. First with federal agencies, with the DoD, with NSF, with CDC and DHHS, with various agencies within our Commonwealth. We are the primary modeling group for the Department of Health here, and provide them a lot of analysis every week. And then local groups, counties, the multiple universities within our state, the hospital system within the state. And the way we do it is we have constituted this team of about 80 of us back in February, March timeframe in 2020. And we've been briefing all these agencies. About 7 to 8 briefings are given. Those briefings are used to solicit new questions, and then we are back to new set of answers in the next round. It's a very intense process, but very satisfying, challenging as well to do science in real time like this for weeks. And it's been quite successful on the whole. So if you go to, for instance, for the web page that the Department of Health has, you will see analysis that they do based on the briefings we provide and the data that we provide them. So this is one snapshot of a page that you can see. And they update this every week based on the presentations. Our slides are linked to this. And the reason I say this is because I think that goal PathCheck has to work with communities, with governments, is something that is important in these projects. And we've now had experience about doing this for a while with COVID. We actually happen to have participated in almost every large outbreak response since 2005. We were part of the H5N1 planning work at the Office of Health there. And then for the 2009 pandemic, then the Ebola work and Zika, and then finally COVID and a second Ebola outbreak as well. We built a number of dashboards. Rohan mentioned this. I think many of you mentioned things like this. Christine, I think you mentioned this too. So we have a dashboard, which we call a surveillance dashboard, very similar to Johns Hopkins work. Started around the same time. We think there's some new features here. Their work is also very nicely done. But it really tracks the disease in the entire world. And the data is available now. We've basically collected data from various sources. You can use it, you can download it in any form you want. We have another dashboard called the medical resource demand dashboard. This basically tells you the resources, pressure of use of resources in terms of PPEs and hospital beds and such, ventilators across the country. We started this for the state, and then we've grown this to the entire country. And it's again updated weekly based on our analysis for various groups. The surveillance dashboard is updated twice a day because of the need for real-time tracking. We started work with Stanford on a social distancing survey dashboard that has got some results, but is not complete yet. I would say that has stalled a little bit. And finally, we build a mobility impact analysis dashboard. This is only for our state right now, and it is not completely open, although you can see a version of it now open. We were thoughtful in not making this completely open because I think interpretation of results from such a dashboard is important. And done wrong, it has actually potential possibilities of misunderstanding. So this was done with Yuri Leskovic's group. Serena Chang, Yuri did an amazing job in their Nature paper. You might remember that. And we basically worked with them to build this system out. This allows our state planners to really, tune the knob. They're saying, if I reduce mobility, interactions at restaurants or essential retail workers or other places, what sort of change do I expect in the next couple of weeks? We're building yet another dashboard for vaccine hesitancy. And for forecasting, we provide information directly to CDC and Nick Reich's group at UMass, which maintains the COVID hub work there, and CMU participates in it too. Brian, I'm sure you'll start working with Ronnie very soon on that project. So we provide that information to them directly. So let me give you one example and then stop and we can take questions. First, before I proceed to this, we are working with Indian scientists, IISc in particular, to understand the spread of disease there. We are starting to build a forecasting dashboard there. We'll make it open in the next 2 weeks or so. We invite participation. Our goal is that much like what we've done in the US, this is not going to be a single forecasting model. That doesn't work very well in our opinion. So folks from your team here and others are all most welcome to participate and add to this. It's hopefully a community resource that people can use. We are also just put out a medRxiv paper on vaccine allocations in one of the states, and we'll grow it to the entire country. We think that's an important question. And we are starting to do work on genomic surveillance, which will connect us to the work you all have done in contact tracing apps, as well as new work on understanding how variants of concerns might arise. So let me quickly tell you about vaccine prioritization. Rohan, I have 5 minutes, you think?
Yeah,
Okay.
5 minutes would be good.
Okay.
Yeah, yes, go ahead.
Yeah, okay. So we started doing vaccine allocation in the US and build out a fairly detailed analytical pipeline. And there are multiple considerations. How do you assign these, allocate vaccines, various objective functions? How do you scale it to a national scale system? So we studied a couple of different questions, but also the computing part was, I think, so quite interesting and exciting for us. We were able to build what I would call a hybrid cloud of supercomputers. We got access to the machines at Pittsburgh Supercomputing Center and our cluster, which has got another 20,000 cores. And we essentially synchronized, had an interesting dance between the two machines, where in the daytime our machines were used, and the evening the Pittsburgh machine was made available to us full time. And we would do the calculations and bring the numbers back. So it was quite exciting to do this, and created very large pipelines. If you want to do vaccine allocation, for instance, you had around 6,000 simulation instances nationwide, produced fair amount of data. So just an interesting computing challenge that we can talk about later. So let me talk about what particular problem, which I think is a nice way to end the talk, because it connects to the app that you folks have made as a part of this effort. Ramesh, I know, played a big role in building that app. So the idea was to try and allocate vaccines based on social contact network properties. And it is a folklore that degree-based heuristics work quite well. In fact, Brian pointed out another application of degree-based heuristics in his work. But if you start doing vaccine allocations, it is not clear that they would work in this particular context. First, because the mathematical results are for very structured random networks. And second, there are many, many time varying aspects to COVID that were not studied by any of the previous work. Like that, the vaccines come online at certain time. The number of folks who are sick is changing rather rapidly. There's a lot of background NPIs in place. There's vaccine hesitancy in place. All this was not considered in the past. So it's not obvious that degree-based heuristics would work. The bottom line is they actually work very, very well, it turns out. And I want to really try and make a case for this, especially for places like India, where vaccines are still in very short supply in many parts of the world. I think it's going to be a good couple of years before people get it. So if goal is to try and reduce the incidence, we think this is useful. So what is the challenge here? I'll skip through the details, is to estimate degrees. So it turns out we don't even need exact degrees. Back to the example that Brian talked about, robust optimization, an estimate of the degree is good enough. It does very, very well. And we think that digital contact tracing apps can be easily modified. In fact, they have much of the information to provide you with an estimate of the degree if once the app is used at a reasonable level. And the way the thing would work is you can basically be told in our simulations, we say whether you are in high, medium, or low degree bin. And that's all, actually 4 quartiles. So, first quartile, second quartile, third or fourth. And we only pick people from the first quartile. No ordering is necessary beyond it. And it still does very, very well. So we hope is that just that much information can certainly be picked up from a tracing app if it's used, in a manner that is reasonably pervasive? That's a question that needs to be figured out. Of course, there are issues in terms of fairness, in terms of misuse of it. There are a lot of questions I get asked whether people might, change their behavior and make themselves to be social butterflies and to try to get vaccine. I think in many places it has gone the other way around. We're trying to get people to take vaccines rather than the other way around. So I think this is potentially likely to be useful. It can reach people very well, in our opinion. You can actually modify the degree with other demographics. You can actually do it in a way, and we can talk about it later, where you can just let a person know on their phone that they are selected for a vaccine based on this information. And I think that just that would do a amazing job. So I'll stop here with all the details. I want to really highlight the role of transdisciplinary team science. As I said, this is not my work by any means, but I think team of this size and working together really can produce very good results. I also want to point out flexibility and agility. And finally, I think you all, of course, know this, but social, political, and economic considerations in pandemics are increasingly becoming important. In fact, I would argue are actually the central pieces of solving this puzzle. It was very easy to stall the pandemic had we all solved problems that are of this nature. And finally, communicating scientific results. I must say that COVID has been good in some ways, but also it has also brought this issue where I think many people have suddenly become modelers. And so there are many results out. It becomes very hard for policymakers to decide which are the right results, which are not the right results. So they need to be communicated with some thought. So with that, I will stop and we can take questions when all the talks are done. Thank you very much, Rohan and Ramesh.
Right. Thanks a lot, Professor Madhav, for the talk and for sharing all the information about your recent works. So with that, I would like to quickly thank all our speakers. Unfortunately, Professor Anurag could not make it. He had an unexpected emergency that came in. So thank you once again, Dr. Brian and Professor Madhav, for giving this talk. So we could move to Q&A right now. And so people can feel free to use the chat option in the Q&A, and we can take those questions up, or the Q&A section as well. So with that, if the panelists have any other questions, please unmute yourselves and you can ask. Thank you.
We can start with a question. First of all, thank you, Brian, and thank you, Madhav, for the wonderful insights. Madhav, if we can start with you in terms of this partial observability problem, where we only see a small part of the population and only a small part of their activities. How big of a problem that is, or you think some statistical sampling methods may be good enough? So what's the trade-off there, and what's the best way to deal with it? You gave some examples of even looking at number of contacts, but not only it's partial observations. So I want to get your kind of high-level thoughts on how to deal with the problem of partial observations.
Sure. I'll give my view. I'm sure Brian has a view. Hopefully it is concordant. Otherwise, we'll see how it goes. I think that it's a big challenge, but more and more data is becoming available. At the same time, we might feel that there's enough. I don't think there's enough data to ever solve this problem and make it perfect. So I think algorithms should be designed with that in mind. And they should be graceful in that more information you get, the better they would become. That would be the way I would address it. To your basic question though, two big instances that we have found, which I would say scientifically are very exciting, that have worked very well is vaccine allocation. We think that it would do very well with very simple form of degree estimation, which we can do either through apps or even simple things like asking people a few questions and estimating their degrees. And as I said, we don't need exact degrees. And this is a part that scientifically is interesting. The final algorithm doesn't need the social network, doesn't need the simulation or any of it. It just says, if you come in, if I can estimate your degree and essentially decide which bin you lie in and provide that, it will do well. We had a similar result for contact tracing. I didn't get a chance to talk about it, but we did work with VDH. We think we could use some information of whom to trace further, because human contact tracing, because digital contact tracing, although it's useful, Ramesh, has been challenging. People have not been able to get to everyone. But human contact tracing has limitations in terms of how many human resources you have to put to these as tracers. But again, helps very well. So I think the general trend is one where you don't look, there's a sort of concept of not looking at the entire network at all, or looking at it in a very partial way. And I think in practice, simple heuristics might suffice. How to prove this in a provable way is a question that I think Brian and Milind have started, and I would love to hear from him. We have some basic results in our contact tracing paper that I'm happy to share with you all. Ramesh, you're muted.
Yeah, thanks for that, Madhav. Brian, would love to hear your thoughts on this problem of partial observability of population and their activities.
Yeah, I think this is just a really pervasive challenge for applying a lot of network-based methods or even a lot of modeling techniques. So I think Madhav is right that there are a lot of useful cases where partial information is perfectly sufficient, and that's because there is a lot of regularity and a lot of structure in the way that networks or interactions typically happen, right? So if maybe in that we've seen in some of the theoretical analysis that we've tried to do, there are plenty of adversarial or worst case examples where the structure of the population is such that you really sort of need to fully observe everything to get anywhere. But those are fairly unrealistic situations, right? Typically you can use features of networks like like high degree nodes clustering together, or the presence of community structure, or all of these kinds of regularity that have been observed to do better with less information. But then going forward, it's still, I think, there's still challenges in doing this really at scale, because even when you reduce the amount of information that you need to collect, if you're still talking about doing really gathering any information about network structure or population scale is pretty difficult without large scale adoption of digital digital solutions, right? Like Madhav was talking about. And if people are willing to provide that information, then that's wonderful and gives us a lot to work with. But if people don't adopt those technologies at really large scale, where we have access to that data automatically, then it becomes really difficult. And that's where I think we need to find proxies that can be collected or observed at scale, but that don't require asking people specifically about their interactions.
What are some good examples? I mean, a lot of people who are watching this, researchers, enthusiasts working in digital and public health. Any examples or any algorithms or anything that you can share?
Yeah, so I think there's right. So this is about like methods don't require access to information about social interactions per se.
Yeah, the examples that Madhav said, like if you wish you had this data, but clearly we won't, and maybe we have only data for maybe 1%, maybe 5% of the population, from that you want to start making some reasonable guesses, and even not just observations but even suggestions for policy interventions. What are some algorithms? What are some good papers that you like?
Yeah, sure. So thinking about network interventions specifically, so there's been some nice work, for example, actually kind of coming out of development economics recently about seeding interventions under limited information. So for example, some of this was by the recent Nobel winners at MIT, right? Esther Duflo and Epidemic energy. And leveraging people's own knowledge about their network structure, and to just asking them who's influential or how they would disseminate information in their community, that can often work fairly well. I think there's still a lot to be done there, because that doesn't quite connect to the kinds of data that we might have available at larger scale, right? So for example, if you maybe at larger scale, you can observe things like some of the affiliations or places that people spend their time, right? It's easier to know something about where they work or where they live or something like that, right? And this is, I imagine Madhav, right? This might be this must be like a lot of the sort of information that you draw on in modeling. And so I'm actually curious to hear your perspective, Madhav, on how that sort of observable information suffices to let you sort of capture more detailed relationships.
Right.
Yeah, like some of the work we do, we involve, prior data from prior pandemics or prior waves and so on, but it's always unsatisfactory. Madhav, anything that you guys are doing or you've seen
it's a very good question, Ramesh. Prior part is useful, but I don't think so. We have understood how exactly to modify it in the current setting. There's always a twist to the current life. Having said that, I think the digital traces that are being produced by folks as they go about doing their daily lives is a very important source of information. It is, of course, riddled with privacy questions, right? But I think one can overcome some of the challenges as far as privacy is concerned using digital traces. I'll give you, an example. We just started working with Google, and our paper used their flows data that they were able to provide us. It was completely anonymized. It's done at an aggregate level. It flows between small regions. So guaranteed, it has got differential privacy layer built on top of it, along with the aggregation, but still was very useful in understanding what would the onset of flu and various interventions in New York City. That's a paper we just published. But along with it, you can also potentially make systems, Ramesh. I think that's what your question. What can the community do? I think community can take this data and produce basically this idea of a synthetic digital twin. So maybe Google and we can all work together, take this and produce a synthetic representation that has the statistical properties. And maybe this can be verified with the real data, but is never put out in a meaningful way, because that's the best that could be done with data sets like this. But I think the digital traces has it. Imagery data has a lot of information built into it and could be used. But all of it will just give us some view of this large elephant, if you want to view it that way.
I think there are some questions coming in, but if I can ask a related question, which is, and I know, Madhav, you have been involved in advising some of the government entities. I mean, it sounds like it's a risky business to be in the prediction world, right? It's like being a weather forecaster in Boston. You can almost never get it right because the weather changes in Boston hour to hour. And we hear about waves, we hear about prediction. I mean, they're almost never right, no matter what. So what are some ways as a scientist to deal with the fact that the stakeholders don't understand what we mean by predictions and models?
Right. It's a good question. So one small plug for a virtual organization, by the way, we have built out, and Ramesh is actually one of the advisors. But the reason I bring it up is these questions are being discussed as a part of that organization. It's an organization to bring together epidemiologists across the world. But let me highlight one first challenge in epidemic forecasting, which is even harder to me in my mind than weather forecasting. And it's closer to stock market forecasting in that sense, because our forecasts are essentially endogenous to the system, right? So if I forecast and my forecasts are dire, then many times people might change their behavior and you might not get the result. So the notion of wrong or right itself is not so clear. In weather, at least you can measure it and say, yes, the forecast is wrong, it was provably so, or right, probably so. Here, this becomes an issue. As an example, our colleague in CDC had actually talked about fairly strong outcomes in the Ebola crisis very early on. And the Neil Ferguson's paper, if you remember, in April, came out with fairly dire consequences for the outcomes. A lot of people criticize both papers, but I actually stand by both of the work, because I think that they're first very clear about their assumptions, and people change their behavior post those papers, and we still had actually fairly large outbreak, as we saw. So back to your basic question about how do you communicate this, is really hard, and I think this is why we have been very thoughtful First of all, we have never tried to forecast anything beyond 4 weeks maximum. We think it doesn't make any sense at all, given the constant behavior adaptation that is happening in COVID. Second is, we have tried to be transparent with all our assumptions. Third, we also tell them different viewpoints, not just our models. We encourage them to look at other models at the same time. But after all that, there are many times, in fact, most of the times, the exact numbers are off. But what we have been reasonably right, Ramesh, in our case, is the general trends. We are able to say that if people behave this way in fall, then we might get a large outbreak. We were right about it. Our magnitude might not have been right, absolutely not. And to some extent, you can say it's common sense question, but we were able to give them some range of what would happen. We're able to tell them now things are starting to go in a direction that you need to be more careful. So forecasts, not necessarily numbers, but something that allow them to make effective decisions should be the goal rather than precise numbers, because precise numbers are not that sensible. And this, having said all that, we were, there's a lot of pushback. We are not, we had challenges. Let's say I leave it at that in a forum like this. But we had challenges from various places. People felt strongly about our forecast. People wrote mails to us about our forecast, saying that that is troublesome. You are destroying our livelihood. And I can understand and I can sympathize with their viewpoint, but our goal was not to do that at all. It was just to tell them that this is important.
That question was from Nishant, so I just wanted to acknowledge his question.
Christine has her hand up, I think. I don't know whether it is.
Go ahead.
Yeah, so I have a question that's a little bit related. So we've been doing modeling as well here at PathCheck and also with XPRIZE. So that's how I know PathCheck and how I know Nina and all of us were in the XPRIZE together modeling. So my question is really about a challenge that we're having right now is benchmarking. So right now we're trying to figure out what the best model is going to be for the pandemic. And we're wading through preprint literature and we're wading through publications and we've cloned the CDC repo to see, whose model is doing the best historically. And so my question for you really is, how do you think that we can sort of make sense of the scientific literature and have a single measurement? Because there's also different measurements everyone's using, right? They're using different windows of time, 2 weeks, 4 weeks out, 6 weeks out. Are you measuring it with MAE? Are you measuring it with MAPE? Are you measuring it with RSME? So how do we as a scientific community get organized to figure out the best way to model this pandemic in your estimation?
So Brian, you want to go next? I'm doing all the talking, so I'll let you start and then I can speak.
Okay, yeah, I can start off at least here. So I think I think prediction really has to be contextualized relative to what decisions you're trying to make based on the predictions, basically, because of exactly of what Madhav talks about, right, with inventionality between predictions and responses, right? That really highlights the fact that these are not separate things, right? You're always predicting the consequences of doing some specific thing, right? And maybe that's the thing that people would have done without any intervention, right? And that's you're trying to guess something about people's behavior. But then, from that, I don't think that there's a single right answer of whether we should be predicting 2 weeks out or 6 weeks out. Right? It's more that as a community we should be working with the other stakeholders, right? With the governments or communities that are trying to make particular decisions, and then asking, okay, if you're trying to make a particular decision about how to allocate healthcare resources, you're trying to make a decision about whether to institute impose some mobility restrictions, then for those decisions, at what time scale do you need predictions to be accurate, and what way do you need them to be accurate, and then define a set of targets based on that.
Yeah, so if I could add to that, Christine, I think Brian summarized it well. In case of forecasting for the epidemic dynamic, we sort of, after the 2009 pandemic, A group of us got together, and CDC was influential in bringing us together. Ronnie is part of that group from very beginning. For instance, Alex is part of the group as well. Matt Biggerstaff is playing a big role, but has led to this finally a team called COVID Cast right now. But we were doing this for influenza as well. So for 10 years, a lot of scientists, everybody who was interested was invited. They were setting up the challenge for influenza, which has got more data, and so it's relatively more tractable than COVID. It's not one shot. And every year, people used to model. CDC started providing more and more data, and this is going on for almost 10 years. I think 2011 was the first competition that we participated in. We participated in each round after that. And some teams have done much better than others in a consistent manner, but everybody's model has been useful. So the general consensus has been to do an ensemble style model, works well. It throws out some of the outliers, but those outliers are thrown out with some thought, because sometimes they have been right too. I mean, just because they're outliers, it doesn't mean it doesn't go well. So that's one. And that's where many interesting things about how to curate the data, which metrics to use, how far to forecast has come up, because it has not been done by a single group. It has been done by a lot of different modelers, but also with CDC, folks from DoD, folks from other agencies involved together, so that they can tell how they use the model, what they find useful in this context. So new techniques to measure things have come out. So for instance, one of the things for COVID that has been proposed is a way to evaluate probabilistic forecast. It's a simple way to do it, but at least it's something that the group agreed to doing it, and everybody tries to use it so that they're consistent across the board. They also decide the space and time aspect of it. There's another such project that CDC has just started. I like that project a lot. We've been doing this for DoD for a long time and for DHS before, which is what they call scenario modeling hub. And the idea is similar to what Brian said. Now we are not trying to forecast the outcome in 1 to 4 weeks, but we are trying to talk about counterfactuals. So you decide as a group what might happen. You look at what if cases, saying that today, this is the state, but new variant might become worse, we think. And it's a consensus-based thing, with either, so one case where many new variants come in, or vaccine hesitancy is such that the number of people not having vaccine is small, and you play this out. So the first paper on this was published as a part of MMWR. We like it because it's got really nicely picked up. But I think again, this is a group level effort, which I think in the long run would prove very useful. We've been actually we had worked with AccuWeather for 2 years as a part of ILI forecasting. Their need to do this was slightly different, and that's the only reason I bring it up. So CDC is one kind of stakeholder, but a commercial company like AccuWeather, which also wants to put forecasts out, and they were starting to go in the world of diseases, has a slightly different reason. They want to reach individuals. So their notion of what decisions people want to make is slightly different than CDC's goal of what decisions CDC wants to make. It's like whether I want to carry the umbrella versus whether I'm going to decide how to take care of a large fire potential that might happen if it's too dry a season. Right, the very different levels of decisions people are making. They want to really reach individuals. So I just thought long answer, Christine, but hopefully this gives you a sense, and I can give you more information as we go along.
Thank you very much. Yeah, that's very helpful. So just one quick follow-up. So what do you think is the biggest pain point for CDC right now? What do they wish they had from modelers that to really make better decisions that they're not currently getting? So I guess that's my question, because it's a little bit of a black box. As a scientist, you put papers out and you model and you put things out, but knowing how that connects back to what decision makers really want is a little bit of a black box for most of us. So you are directly working with them, so it would be great to get your insights into that.
I can say a little bit. I would be hazarding a guess because after all, it's their questions. I think the questions have kept on changing, Christine. If you really track the pandemic from March, We started working on it close to January. There was clearly signals that said something could be off. It's only in March that became much clearer to everyone. But one had to, we have tried other diseases which have not turned out to be pandemics. So it's not that every time things go this way. So I think they really, first of all, they want results to come out at a fairly fast clip. They are okay with a 80% answer than a perfect answer 2 months later. Doesn't seem to help them much. Second part that I think they have now accepted, this is in my opinion, again, I could be wrong. I would love to listen from CDC as well, but certainly I can say this for our state. The social aspects, the governance aspects are really important. So as an example, it was not hard to control the pandemic by either asking everybody to stay at home for some period of time. It was a straightforward, intervention to put on paper in terms of writing a paper, but it's useless because it's not operational at all. On the other hand, the other side, which people were clamoring that, let's not mess up our economy and let everybody run through it. Sweden decided to sort of take that route, partially at least, is also not a feasible strategy. And the question is, this answer is somewhere in the middle. But that answer comes not because the interventions themselves are hard to imagine, but their extent and impact, which is governance issues at the end of the day. What do people want is important. And the third part, they really want, in all these models, when people had raised the flag of worry early on, people did not buy into it. Sometime when they're able to hold it back, then people felt, this was a, crying foul, but nothing really happened. So they would like us to analyze the counterfactuals in a way that they can make small incremental decisions as it goes along. And then, of course, the bigger story is, Christine, I think we had it, we meaning the country had it, we never sort of got this in play. Large long-term plans, and I've used this term now many times, but I'll use it one more time because I think it's really important. Somehow, we as a society, the government and the people have a Markovian memory. This has happened, people will work on it very hard for a year, and then funds stop, people lose interest, and they move to the next problem. I think if I've learned one thing, somehow we need to be at it for a long period of time. And just because it doesn't happen, I think that should be a good news, and it should be viewed as a positive and a success for that investment, rather than saying maybe we don't need the investment anymore because this is not happening. So I would say if we can make a case for CDCs and other disease control units across the world, that would be a remarkable thing, because I'm worried that a couple of years from now, the attention will shift. We won't get a pandemic for a while, and then people think everything is done. All these tools will be sitting somewhere. Your tool won't work, my tool won't work. Almost certainly they won't work after a while, because once you don't get funds, it's just dies. Hopefully this is something I feel strongly about, that we have to continue as a team to work on it, but that eventually means support from various quarters.
Thanks a lot. I think we've had a few questions in the chat here. So, yep. So Saswati Sumi says, vaccine seems quite costly. Is that something that's going to be addressed or covered in the dashboards?
We have not put costs in our dashboard. We only talked about hesitancy and the coverage right now. And it's more for US because US cost is not the primary consideration. But I agree with Saswati completely. In India, that is a consideration. And if we build it, we might need the data to tell what the cost is. For a place like India, other places, similar questions will come up. But it's a great question. We don't have it right now.
Very good. I have a question about the work on social networks that Dr. Wilder was doing on spreading things. So you mentioned that you have, so just a quick clarification and then a question. So you mentioned that you choose popular people to spread information. So I was wondering how you choose who's popular, and exactly how they spread the information. So those are my questions. And then if you could just elaborate a little bit more on that, because I'm very interested in that.
Yeah. So this is something that I've really fussed over. So when we're looking for popular people here, really the key thing is that we're not so much looking for people who are individually popular or individually central in the network. We're looking for a set of people who collectively cover different portions of the network, different sub-communities. And so this involves both gathering some data about the network. So this is the kind of subsampling step that I mentioned, where we survey a small number of people in the population about their social connections. But then also there's an optimization problem where we try to we formulate a problem of maximizing the extent of information diffusion on this subsampled network with a limited budget for the number of people who you can select. And then the way that works is that in common models of influence spread, you get diminishing returns to having people who are very close together in the network, because they'll, as your seed nodes, because they'll talk to many of the same sets of people, right? There will be kind of redundancies. And so that those models, when you use them in optimization, they encourage the algorithm to cover kind of diverse parts of the network, right? To find people who are sort of locally central within their own communities, but then to cover lots of different communities. And so that's one part of the question. And then the other part of, how do you actually,
just real quickly,
actually work in some sense here, I guess. The idea is that whoever you select is going to be trained as a peer leader. Sorry.
Sorry, I just wanted to jump in real quick. So when you say that they're connected, do you mean that they have by their Facebook friends or by their Twitter followers? Is that the kind of connection you mean?
This is connection out in the real world in some sense. So it's asking people who do you actually interact with at this, in this context.
Okay, so it's self-report.
Yeah.
How many friends do you have, kind of thing, or in what areas? I'm just curious. Yeah.
It's asking, which people at this drop-in center do you have regular contact with? So actually, your individual network connections. And that's, partly is that, for this population in particular, people aren't typically connected on Facebook. A lot of people don't have Facebook, or they don't have as good access to technology in homeless populations. But then even if they have that access, a lot of the time they're not actually friends with the people who they interact with at the homeless center, right? They're friends with people in other aspects of their life. And so, and I think that's kind of it points out a broader challenge in kind of using digital technologies, particularly in populations that are, most vulnerable to some of the challenge, these public health challenges, the way that even when people adopt technologies, the way that they kind of use them is potentially different.
Very cool. And okay. A question from Nishant Chada. It's they say, my question is for Professor Madhav. You said the results of scientific analysis should be conveyed carefully. Can you expand upon that? How do you think these findings can be presented so policymakers can make informed decisions? And I would just add to that, and also, how do you present it to the public so that they can understand it as well?
Yeah, I don't have a silver bullet. If I knew that, I would be really rich and famous by now. But I can tell you what one should not do. Maybe I think that's the easier way to say it, because it's a long list. One should be very open about their models, first and foremost, when they talk to the officials. Sometimes people get excited and sometimes end up overselling results. So they should really tell where the constraints are and what the assumptions are, in my opinion, because there always are. And this happens, what is not taken into account. Second aspect of it is that models are really there to provide a basis. So working with them, you can really understand the question that they had in mind. A general answer is sometimes fine. And in fact, saying that I do not know what that answer might be is actually equally good. They're okay with that. Third is, I think decision makers are actually quite smart. It turns out they're not they oftentimes don't take our solutions because the other constraints that they have in mind are just not easy to articulate, but they are really genuine constraints. For instance, I don't think so any government had the ability to lock down their countries back in March. This was unimaginable in the Western world and most other parts of the world, right? But finally they did it. And they did it slowly but surely as more evidence came through. Now, because that maybe they were a little late as well. But I bet had all countries shut down their borders and shut down work in 1st of March, this would have created such a big problem because mostly the epidemic might have at least died out a little bit if they had shut it down for a month and a half, 2 months. Well, and then people would have said, but nothing happened. Why did we, mess up the economy for such a long time? So I think they understand it. So if you give them the right reasons, they would find a way to communicate it themselves. Public is a hard question. Again, we have been very thoughtful, Christine Nishant. We have not published much of our work. We just did not think it was responsible on our part to publish the work right then. One of the tool sets I talked about with Stanford, we have not made open. We only have now a version of it open to see what it can do, but not specific data, because the chances of misinterpretation that an understanding that Saraswati also has raised are high. So it's best sometimes not to talk about it in the open and let decision makers have a chance to decide it. It doesn't mean that you're hiding the information. It's just not easy to put all the caveats in a simple dashboard. It doesn't work out that well. So those are my simple answers, maybe very commonsensical ones, but that's what we can go on in detail. Baruch Fishkoff has talked a lot about it from a science communication policy standpoint. It's a very important question.
Thanks so much. I think with that, we will we'll stop the recording because we're over time at this point. But if we want to continue to have questions and have a discussion, we can do so offline. So thank you very much to our speakers and thanks for all the questions. And this has been an amazing discussion.
Thank you very much for the kind invitation. I'm looking forward to interaction. My email is with Rohan and Ramesh. Please reach out anytime. Take care.
Definitely. Thanks a lot, of Samadha and Brian, for spending time with us and the talk.
Take care. Bye.
Yeah, thank you very much for the invitation.
Bye.
Right. So I'd like to quickly point out the next seminar series we'll be having on July 15th at 11 a.m. EST with Diana Stansberry, who's president and founder of the project Global Impact, and Dr. Peter J. Hortis, who's Dean of National School of Tropical Medicine and Professor of Pediatrics and Molecular Virology and Microbiology at the Baylor College of Medicine. So with that, thanks a lot for spending your time with us and see you next week. Bye, everyone.